Alright, today what we're going to talk about is pancreatic adenocarcinoma. Alright, the pancreas, first of all, we're going to talk about the pancreas and how the pancreas exists as a normal organ. The pancreas is a gland in the digestive and endocrine system of vertebrates. It's both endocrine and exocrine gland, which mean it serves both functions. Most neoplasms or adenocarcinomas of the pancreas occur in the exocrine portion, as we'll see later on. The anatomy of the pancreas. Here we see the tail. We see the main pancreatic duct, which should be less than 2 millimeters rather. We see the body. We see the head and the neck coursing over here towards the duodenum or duodenum as well. You also see the cystic duct, common ducts, and gallbladder as well. As you'll find out, sometimes the gallbladder can also be associated, causing high drops, as you see a neoplasm of the pancreas or adenocarcinoma, which can cause the gallbladder to distend, or another common term for this sign is a Courvoisier sign. Adenocarcinoma. What is adenocarcinoma? What is this? Well, adenocarcinoma is a type of cancer that may affect various organs. This means that it can metastasize and spread to many other organs. This increases the chance of this neoplasm to be more fatal. Adeno or adeno means pertaining to a gland, and carcinoma simply means pertaining to a cancer. Well, you put the two together, and pancreatic pertaining to the cancer, you have a cancer of the pancreas, pretty much. Pancreatic adenocarcinoma constitutes for 85% of all pancreatic neoplasms or all pancreatic cancers. Pancreatic adenocarcinoma, it is very malignant, and it has a poor prognosis. As you can see, the American College of the American Society of Cardiographers and whatever the heck it is, they predict that 28, the American Cancer Society, sorry about that, present that for every 28 patients diagnosed with, every 29,000 patients diagnosed with adenocarcinoma of the pancreas, well, you only see a survival rate of about 1,000. So that means that it's pretty fatal. That's like saying for every 10 patients that comes through the door and is positive for pancreatic adenocarcinoma, only one of those will live, and 9 of those will experience a fatality rate or die. Clinical symptoms for pancreatic adenocarcinoma is going to vary. As you get an understanding from your patient of what's been going on and you begin to talk to them, you're going to find out that they're having different symptoms. A big key indicator of pancreatic adenocarcinoma of the pancreas will be your patient's going to walk through, and you're going to notice that the patient the skin is really yellow. Your patient may have yellow eyes, and so you're going to think, oh, this patient must have jaundice. Accompanied by that, your patient may tell you that they have been experiencing some weight loss. They may have been having some itching. They may have been having some abdominal pain, which tends to radiate to the back. They may have enlarged, palpable lymph nodes that they feel on their neck. Well, they also may have dark or irregular colored stools. You're going to see a ton of these symptoms, and a lot of times they're going to correlate with each other. And it's going to be many of them, not just one or two. Lab values associated with carcinoma of the pancreas. Well, there's really no true test or predictor to really catch pancreatic adenocarcinoma. Subsequently, you see elevated amylase levels, but it's not primarily because of pancreatic adenocarcinoma. Um, what you also see is an increase in bilirubin levels, which is going to correlate with jaundice, as we just said. Excuse me. Also, you're going to see elevated liver function enzyme tests as well from your LFTs, liver function tests. Also, a great indicator is the cancer antigen serum marker 19-9. This marker is not used in common practice, but some physicians and surgeons, they use this to pretty much keep track of the cancer, and when these levels are elevated, is usually because the tumor is growing. These markers also help predict whether the tumor or the neoplasm is going to be able to be surgically removed or treated with chemotherapy or whatever, and it's going to pretty much be a predictor for which stage the neoplasm is in, and which how big it is, and the largeness of the tumor. Here you see the normal pancreas. You have the liver posteriorly, pancreas, excuse me, and you have the pancreas. You have all the normal vasculature. Right here, you have the head of the pancreas at the IVC, and as you sweep and scan more laterally, you come into the body of the pancreas at the level of the aorta. Right here, we're in a longitudinal view, or sagittal. You see the pancreatic adenocarcinoma presents as a neoplasm, which obstructs the view of the pancreatic head. Right here, you also see the same thing as well. It presents as a cystic mass, and it's gonna measure a couple of centimeters as well. Right here, you can see it better in transverse view of the pancreas at the level of the pancreas. And right here, especially well, you see this neoplasm. It looks irregular, and it's cystic, complex. And right here, you see the regular vasculature, and this one right here is on the pancreatic head, and it's going to cause compression of the IVC, which may subsequently cause more problems for the patient. Also, many times you'll have a dilated duct associated. Also, you may have distension or high drops of the gallbladder, simply like that. Let's go back. Differential additional diagnostic tests secondary to ultrasound, or not necessarily secondary to ultrasound, but these tests are done in conjunction with ultrasound, or CT scan, biopsy, ERCP, and MRCP, which is a form of MRI that is used to visualize this specific area of the pancreas. Right here, as we see an additional modality being used to actually state that pancreatic adenocarcinoma is present. Right here, you see a normal CT scan of the pancreas as it courses laterally, and you see normal kidney, normal liver, everything normal. But right here, you're gonna see the common bile duct be dilated, and the pancreatic duct, or duct of Wirsong, is gonna of course extend more than 2 millimeters, and this obstruction is gonna be caused by this mass right here, this pancreatic mass or neoplasm. It's gonna be caused by this right here, and so this is another indicator that you're gonna have a carcinoma, adenocarcinoma of the pancreas as well. All right. Differential diagnosis. Well, here's the thing with pancreatic adenocarcinoma, you're not gonna always know that it is pancreatic adenocarcinoma until you either do an ultrasound in conjunction with a CT or a biopsy. You're just not gonna know. So you have to do all these tests, and sometimes you may have a differential diagnosis. Who knows? It may be cholecystitis. It may be choledochal cyst. You may have gastric ulcers. It may simply be acute pancreatitis versus chronic pancreatitis. But in conjunction, you have to do all these things to make sure you're getting a great image. And in the end, the radiologist is gonna read the report and dictate a final diagnosis. Here's my sources. Thank you.